Precision for Women est un podcast dédié à la médecine de précision et à la santé des femmes. Vous y retrouverez régulièrement des témoignages et des interviews des femmes et des hommes qui constituent l'actualité de ces deux disciplines. Je suis Norbert Nabé, votre hôte. Soyez les bienvenus. Aujourd'hui, aux États-Unis, une femme sur 10 est atteinte d'endométriose, mais il faut encore près de 10 ans pour obtenir un diagnostic. Alors pourquoi ce parcours reste-t-il si complexe et comment la médecine de précision pourrait-elle changer la donne ? Pour en parler, j'ai le plaisir d'accueillir Madame Guidone, experte et défenseur reconnue de la cause. Elle est directrice de programme du Centre for Endometriosis Care, un centre de référence basé à Atlanta, et œuvre depuis plus de 20 ans pour améliorer la prise en charge et la reconnaissance de la maladie. Bienvenue et merci d'être avec nous pour cet échange qui aura lieu du coup en anglais.
Can you share with us your personal experience with endometriosis?
First of all, let me say thank you for all the work that you're doing, particularly in Endo Awareness Month, but generally with your innovation and your technology, really leveraging the disease. So as a sufferer, as a professional who works in the landscape, thank you. And we can definitely talk about your test. But my journey, is much like everyone else's. I think that the journey for me was really driven. My journey towards advocacy was really driven on a personal level. I am someone who was diagnosed with endometriosis, early, after only about 5 or 6 years. And it was a very profound time trying to get a diagnosis, but even more so, having access to care didn't change anything. Yes, I got a diagnosis, but I still felt misunderstood. I still felt dismissed. There was this duality of privilege, being able to get a diagnosis, being able to access care, but the care wasn't good, and I didn't know that. I still felt invisible. And so really the journey for me was born out of sheer need. It was really about driving to find answers for myself, because I wasn't getting any better. I wasn't getting the help that I needed. And then sort of down the road, I was looking around at other sufferers who were really going through the same thing that I had. In the late 1980s, they're still suffering and still struggling with it along the way. So I really wanted to amplify the voices of other people with the disease, really focusing my advocacy platform on beyond surface level awareness, but really trying to encompass and incorporate things like empowerment and validation, really focusing on systemic changes, incorporating policy, research funding, educational changes that really change the dialogue around the disease and how we view it and how we view sufferers and how we treat them. Because I know that my care was very subpar for the majority of my journey. And I know that too many people are still struggling with that. So, my journey is not unique or unusual, but, I kind of felt like if not us, then who? And if not now, then when?
During this time, were there a specific time or any events when that decide you to dedicate yourself fully to the advocacy and the care, because you're dealing with patients' care also?
Yes, absolutely. I wouldn't call it an epiphany per se, but there were many moments along the journey where I kind of threw up my hands and said, what now? But I remember distinctly sitting across the desk from somebody who was supposed to be a quote unquote specialist, somebody who was supposed to be an Uber physician, not being heard, being dismissed for the 100th time, planning yet another surgery that hadn't helped previously because all they were doing was just burning the disease off. They were not removing it. Another round of medical suppression that was making me crazy and not working for my pain. I felt really dismissed and trivialized and really helpless. And I said, enough is enough. after hearing stories from others along the way, you know, I felt like that human story for all of us was really being lost. The doctors were listening to reply, but they weren't listening to understand. And I thought, I need to take a step forward here. This is something that is not just a passion project. This really has to be something that I need to get involved in and really try to focus my efforts on making a difference, because even if it doesn't work for me, someone down the road may reap the benefits of that. And so here we are 30 years later.
Yes, that's true. And things happens. We can't say that nothing changed, but still, if we talk about endometriosis, the disease and the care in the US, but despite all these advocacy and medical advancement in your country, why is still endometriosis so difficult to diagnose today?
Yeah, I mean, that's the thing. Is it difficult to diagnose, or are we just not listening? And that's kind of where the conundrum is. And I think it is fair to say that there are multiple reasons. I would say that it really boils down to a combination of systemic, societal, and medical factors. And until recently, there really has been no successful biomarker, non-invasive, or imaging test that really kind of says, okay, we think endometriosis is present. It really is still, the gold standard is still a surgical diagnosis. So people are being disbelieved of their symptoms, so they're not getting connected to a surgical diagnosis and treatment. Instead, they're kind of undergoing unnecessary testing and unnecessary treatments along the way that aren't helping and aren't working. And they're being dismissed and sort of gaslit along the pathway. I think that we're really still facing a lack of comprehensive education among providers as well. And that's a huge barrier. Particularly with a disease like endometriosis, which predominantly affects those assigned female at birth. There's this heavy gender bias, even now, that still really minimizes women's pain and pelvic pain and all of the things that sort of go along with endometriosis that are part and parcel of the disease experience. And in particular, because menstruation is so closely adjacent to endometriosis, there is that knee-jerk reaction to just say, well, it's a menstrual disease, it's a bad period, let's just suppress the period, let's give them a hysterectomy. And that's really not the case. But I think it really comes down to listening to patients, taking their pain and their symptoms seriously at the first signs, and being educated on what to look for. The disease doesn't present the same way in every individual. It has different manifestations on its own. And if someone doesn't know what to look for in their patient, it's very easy to dismiss them. And that gets internalized as a patient. You start thinking, is this in my head? Am I imagining this? Am I weak? Am I just not strong enough to handle my symptoms? Am I making it up? You really have to look at the signposts in your patient and say, what is this pointing to in terms of a diagnosis? And don't dismiss things like a collapsed lung or a sciatic situation where the pain is cyclical, or where they have chronic pelvic pain far and apart from menses. These are all things that can be present with endometriosis and often are, and they're just routinely dismissed. So we have a lot of barriers. The system was not built for endometriosis. It is very broken, and trying to navigate within that system, it can be very arduous.
Yeah, thank you. And we see it's a multifactorial question. And do you think it's like a chain, and with the weakest part who makes everything fall down? Or do you think it's just many things to treat at the same time? And you said it, and there's the physicians training, or the health professionals training, because maybe it's not only a physician deal. There's There's also a big societal taboo. We can say that. And
Oh,
even if
absolutely.
women health is becoming very, very big in the US, we can see that even from France, with all this big policy movement from Jill Biden, with the call from RPH, and we can see it's going to move. I don't know if it moves in the field really, but it's going to move, or maybe it's a matter of technology. And of course, I'm talking about this biomarker that could help, but won't by itself change and
Right.
do everything.
Right. No, I think you make an excellent point. As someone who has that benefit of history to look back on, we can say sort of what are those main barriers? D, all of the above, right? It's physician training and lack thereof. Doctors are still receiving basically what amounts to just a cursory education on endometriosis during school, right? Um, and we know from current research that that's across all disciplines. That's an interdisciplinary problem. We know that GPs, GIs, OBGYN residents, every discipline has indicated in studies that they don't feel educated enough or well prepared enough to recognize and really take on the care of their endometriosis patients. So that's a huge problem. And this can be intersectional and compounded with that societal narrative that dismisses pain, particularly menstrual pain, pelvic pain, things that are associated with endometriosis. It's very easy to normalize or trivialize those. And that leads again to delayed care seeking, delayed diagnosis. And then when we talk about sort of on the innovation side, again, it's always been a surgical diagnosis, right? And again, that's still the gold standard. We want that histology, we want that pathology, and that is surgical. But if we could, and I would back that up by saying sometimes folks can't have surgery, they can't access it due to affordability. It's in other reasons it's inaccessible, or maybe they don't want surgery. So we really need that innovation that makes that diagnosis attainable early on, because that is the first step. We can't do anything without a diagnosis that is substantive or meaningful. Yes, you can throw medication at it, you can try lifestyle adjuncts and other things that can help your pain, but if you don't know what you're treating, we don't know how effective those clinical treatments will be.
So let's take a few minutes about care, because maybe you can explain us your experience with patients in the Center for Endometriosis Care, because I don't know if everyone knows about that. And do you feel in the US nowadays significant difficulties to access to care
Yeah,
still?
absolutely. So as a tertiary center of referral center for endometriosis, we treat patients from around the world. So we have a very diverse patient population, but at the root of that, the issues are still the same no matter where they come from, whether it's down the street in Atlanta or if they're joining us from Kenya or anywhere around the world that they're flying in from. The biggest problem that we still see across the endometriosis landscape is access to care. And that's a common issue among all specialists for the disease. We are one center. We can help as many patients as possible, and we try to do our very best. But there are 200 million people living with endometriosis. We can only treat so many, right? And unfortunately, too many patients are still being shuffled, as I was, through that really fragmented silo, through a really broken system that's misdiagnosing them and dismissing them and treating them quite poorly before they find us. And unfortunately, even when folks do find those centers of expertise, they're running into those cost and insurance barriers. So we've got a broken reimbursement system that prevents universal access to care. We've got geographic limitations. There's not a specialist on every corner. Overall cost of specialized care with the different specialists that folks will need to see, whether it's imaging and radiology or pelvic floor physiotherapy or gastroenterology. there are all cost components in that. And it's very, very heartbreaking to see how many people are still suffering because of all these factors that were present when I started the journey. And again, we're one center. We do the very best we can. I wish that we could help millions. That would be wonderful. But the reality is we are just a small private practice. Even though we're very high volume and we treat over 500 patients a year, that's a drop in the bucket. And everybody is still having the same issues no matter where they come from. So that's something we really need to work on and continue to work on. It's been a flashpoint for endometriosis for as long as I have been in the advocacy game. This is something that we have been working on for decades in terms of reimbursement and the coding issues and the structure around how patients with endometriosis connect to and receive care. But it is an ongoing battle.
Yeah, there's a huge need with the very basic facilities. And at the same time, and that's what maybe we can talk now is, this revolution announced of some precision medicine. Do you think by your regular practice that this could be a new approach and this could be something interesting for all these patients who've got this one disease, endometriosis? Is this something that comes, on the scientific and professional business?
No, absolutely. I think that you just hit a very, very important point. I think precision medicine holds incredible, tremendous promise. I think that's the direction we should be going in. When you start tailoring a patient's treatment towards their genetic and molecular and clinical profile that's individual and specific to them, you're moving away from a one-size-fits-all approach, which clearly has not been working. This is not a one-size-fits-all disease. It manifests very differently in different patients. Patients respond differently, even to the same treatments. So when we talk about looking at those effective treatments and earlier on in a patient's journey, then you start treating the human being. You're not treating just a lesion. You're not treating just a disease. You're treating a whole person. You're treating a body, a human, a soul. So precision medicine is absolutely the way we need to be going. There has been a shift over the years towards more shared decision-making and patient-centric care, but precision medicine is really going to transform when we start adopting it on a widespread level. I think it's really going to transform outcomes. I really do.
All right, let's talk now maybe about diagnostic because, Zyweg is about this salivary-based test. To your experience, do you think that being able to give an accurate diagnostic could change nowadays something for the life of this patient, and the way they could be treated and on the way the healthcare system could transform itself and being maybe more efficient or useful for everyone?
Oh no, I think it's absolutely tremendous. The non-invasive diagnostic search has been one of the most important research goals that has been tried to be attained for many, many decades. That has always been a priority focus of research. So when we start talking about things like combining the AI and the RNA and doing an analysis that can really intervene so very early at very first signs of a patient's journey, that is game changing, right? That's something that's empowering patients to advocate for themselves. For example, if a mother has a daughter with maybe suspected endometriosis and she has endometriosis herself, she's going to maybe think to herself, I would like to get my daughter tested right away. She's got that knowledge, she's got that background. You can intervene even in the absence of symptoms, even before the disease becomes such a profound, painful problem. So you're really arming patients with tangible data, things that they can use to break down the barriers of disbelief and misdiagnosis. You're taking chunks out of that delayed diagnosis pathway. You are helping physical health, maybe fertility preservation, if that's something they're interested in. But you're also contributing to an improved quality of life and the emotional and mental health aspect, because you're giving a tool that now says, okay, we believe your pain. This type of test can really, hopefully, potentially, possibly drastically reduce the timeline, allow for earlier appropriate intervention, diagnostics, treatments, tailor that treatment. We were just talking about precision medicine. That's what precision medicine is. It's that early diagnosis, and it's that timely intervention on a personal level. But I think there's more to the picture even than on a personal patient level. I think when we're talking about tests of this nature, these are things that can be incorporated into research. I think these are things that can really help researchers kind of gather broader data sets that lead to better insights on disease prevalence, potential risk factors, more disease subtypes that maybe we're not even aware of yet. Could this even help prevent disease progression? We're really talking about integrating something novel and so very innovative into a really broader multidisciplinary approach to care. It's really going to change that early detection paradigm and improve that pathway to more effective treatments, more comprehensive provider education, better research. Yes, of course, we've always got limitations, right? We need to think about how to get it adopted into clinical practices and get it covered and affordable and all of those things. But it's incredibly exciting. It's really indicative for the first time of real progress. And I say that as someone who's very jaded and has been here a very long time, and I've seen all the biomarkers and all the tests come and go, but you're using your test. It's out there, it's available, it's working. And for someone like me, who has been pushing that boulder up hills for 30 years, seeing something like this really tells me that there is hope for real progress, because it's here, it's coming.
Well, it's kind of the end of this talk. You got this huge experience on this disease. It's still a small hell for many women who get lost, and on their journey with endometriosis. What could be a good message for them?
I think the most important thing that we can tell someone with endometriosis is that their story matters, their pain is real, their voice matters. And I don't want them to doubt themselves. I want folks with endometriosis to know, first of all, you're not alone. And this is not a linear journey. You are going to have better days some days, and I want you to celebrate those wins, and I want you to honor your journey, and I want you to show yourself grace. But I want you to also remember that it's okay to keep asking questions. It's okay to seek second opinions. And I think it's important too for folks to know we have an incredible community for the most part, right? We have an incredibly supportive and educated patient community full of so many wonderful advocates, professional advocates across the spectrum who work on things from billing to clinical care and everything in between. We've got wonderful practitioners from all disciplines, incredible scientists and researchers like yourself who are really pushing innovation forward and making a difference. Collectively, there are changes being worked on by a wonderful community that really is trying to make that rising tide lift all the boats. So I think that there's a lot of hope there, not just in March as Endometriosis Awareness Month, although that's when we see a lot of efforts ramp up, but year round. There are things going on that maybe we don't see them on social media or we don't hear about it in the news. I promise you, I am behind closed doors every day with people who care about this disease, incredible surgeons like I work with, fantastic patients and patient advocates that I see every day, scientists like yourself. There are a lot of folks out here trying to make a difference who believe that there can be better.
And this time, as a conclusion, maybe for the other side, all these people like policymakers and physicians on the head of everything that could one day make a change possible, what could be your best advice to them?
Yeah, I have a few messages. Now,
Yeah, I
I
guess.
think
Take your
the
time.
most important thing that they need to do is listen to patients, right?
Mm,
Patients will tell you everything you need to know about this disease. The lived experience is immeasurably invaluable. It's the biggest part of the puzzle with endometriosis. Patients are the experts in the room. They are not only experts on their own narrative and their own body and their own lived experience, but they are the expert on how the disease affects them. And so science and policy really need to come together more and address not just the biological aspects. Let's not just look for one treatment for one person. Let's really talk about achieving strides together, using that biopsychosocial model, really putting research and training and systemic change together. And I think that's how we achieve those meaningful strides in the disease. But you got to listen to your patient.
Thank you so much for this time, Isa. It was wonderful. Thanks a lot, and see you soon, I guess.
Absolutely. My pleasure. Thank you so much.